Lisa Kelly, Executive Director of Mental Health Awareness in Michiana.
I'm Anna Swatsky, Director at The Source.
So we are delighted to have you today at Advancing Trauma-Informed Care, Caring for Our Communities and Ourselves. This is our third spring summit in Elkhart, and the response to this one was incredible. We have folks who could not register who are online, and so we want to welcome our virtual attendees as well. And we will be recording this, so if there are people who who couldn't make it, we will upload the recording to our YouTube channel probably in the next few days. So this will be publicly available afterwards. So I want to thank our sponsors. So Bowen Health, Care Source, and MDWise are sponsors for the event today. And the sponsorships are really important because for us to do events like this free of charge to the community, we have to have financial support. So I'd like us to thank Bowen and Care Source. Thank our planning committee. So every event that we do, we pull together a planning committee of other organizations, because what we have found is that the summits are better when we involve other organizations and other points of view, and we have had some rock star planning committee members. So Jennifer Lefevre from the Melbourne Family Clinic is a return planning committee member. Thank you, Jennifer. Missy Schrock from the Center for Healing and Hope. I know that Missy was out of Jose Elizalde from the Source. Thank you. Ishia Smiley from Tolson Center. Thank you for this year. Maple City Health. Thank you, Kevin. Triple P Positive Parenting. Thank you very much for your help. So everything we do is better because of collaboration, and we thank our planning committee for their time and expertise. I also want to thank the organizations for tabling today. Please visit the vendors in between at the breaks and at the end, because one of our goals is to make the community aware of what's the really great work that's happening in the community. And so having people represent their organizations is an ad for the summit. And so please make sure you stop by and visit people and learn about their programs. Okay, so we will be keeping breakfast items out all morning until they go away. And then there's some additional water and soda that we'll put out that you can help yourselves to as well. Okay, so I'm going to introduce Anna from The Source, who's our partner for today's summit. You've been a great partner, so thank you very much to The Source. And would you like to say a few words of welcome?
So I remember the first time I heard about trauma-informed care. I had just moved to this country. I was new to the field. I was a home visitor at CAPS, and I attended a mental health breakfast at Oaklawn. And they were introducing this concept of what they had done to implement trauma-informed care. And what stuck with me was the depth of what it took. So I remember them talking about getting rid of the distinction between staff bathrooms and client bathrooms. They talked about the color of the paint on the walls, that you're training janitors, van drivers, therapists, and administrators. It was this in-depth process. And so then watching this over the past 10 or so, 10, 11 years has been really interesting to see how each agency does this, incorporates it, tries to. It's so hard, and it's so hard to maintain and to do at all of these different levels. And to think too about it's what we do, but the biggest thing is how we do it. And that is so hard also to get every staff member at every level acting in these ways. And for all of us to consistently act in the trauma-informed way is difficult because we all have our own stuff going on. And so this idea that came out of the planning committee and out of MHAM to say, let's revisit this, let's look at this. What are we doing well and what could we do differently? Just seemed like a really brilliant, like 10 years or so in, it seemed like a really appropriate check-in. So we're thrilled to be doing this. I hope this can be meaningful for everybody and for all of us too. I love, we're all connecting and having a good time. Let this be that for you. We know that learning is good for our brains and good for our own nervous systems and trauma. We know that connecting with people, having good food, all of these things. Let this be a time of trauma-informed care for you too. And then at the end, to walk away with a nugget, something that you can actually implement and do in your agency, in your life. So thank you for being here, and thank you to MHAM, and have a great day.
So our keynote speaker today is Dr. Michelle Miller. Dr. Miller is an assistant professor and licensed clinical psychologist at the IU School of Medicine, Department of Psychiatry. She serves as the principal investigator of the Perinatal Traumatic Stress Lab at IUSM, as well as the director of the IUSM Traumatic Stress Clinic. Her research interests focus on how reducing perinatal traumatic stress may improve maternal, mental, and physical health outcomes, such as reducing perinatal complications and improving overall functioning, which can ultimately enhance family well-being across the lifespan. So we are delighted to welcome you, Dr. Miller, to present Trauma-Informed Care, Achievements So Far and Room to Grow. Welcome.
Great, thank you so much for having me. Today I'm going to talk a little bit about achievements so far and room to grow. Just very briefly, here are my disclaimers and some of the grant support that I've received. Okay, so today I want to talk about what I'm covering today. I want to very briefly define trauma-informed care and then get back to making sure we're all on the same page. Talk a very little bit about the origins of it, and then talk about what's going well, where do we need to improve, and what is the future of trauma-informed care like? What does it look like? I'm a maternal health researcher, so I'm also going to weave in some of my research that I've done and how that is connected to trauma-informed care, especially in pregnant and postpartum populations. So to start off with, right, why is trauma-informed care so important? It's especially relevant because a personal history of trauma is so common. 60% of adults and 40% of children ages 6 to 17 report at least one type of childhood trauma, such as sexual abuse or domestic violence. Trauma is not addressed, particularly when it occurs in childhood. It can be a root cause of physical and psychological illness, health compromising behaviors, injury, social problems, and disability across the lifespan. As the majority of both the US and global populations have experienced a traumatic event in their lifetimes, it's becoming increasingly necessary that individuals and organizations look at how their policies and their procedures impact individuals who've experienced trauma. So trauma can be defined in many ways. It's not just what people think of when they think of trauma, right? Like a car accident or sexual assault. SAMHSA, right? The Substance Abuse and Mental Health Services Administration finds it as something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful or even life-threatening, and that has lasting effects on the individuals. Note the 3 E's: events, experience, and effects. Right, we notice that how one person defines trauma may look a little bit different based on how they're experiencing it. So types of trauma can be broken down into even further categories. Some trauma is acute, which is a one-time event, such as a sexual assault. Some chronic or complex, like witnessing or experiencing domestic violence or human trafficking, someone with a substance use disorder, or living unhoused, as well as historical trauma. Historical trauma reflects systematic oppression of a particular group across generations and disproportionately affects people of color. This can include genocide, slavery, police brutality, or forced relocation. And these definitions also include even more types of trauma exposure, right? Almost feels like the more that we measure and look, even more can be identified. So some of which is pictured here. And our patients or the folks that we're working with are coming into the room potentially having experienced so many different types of trauma across their lifespan or in their history or in their family's history. When we think about all this kind of individual and collective trauma in a variety of ways, they often may not be disclosing to us, but of course it can be affecting their life in profound ways. So again, very quick refresher. Trauma-informed care is that whole person approach to care that acknowledges the impact of trauma on health and is inherently patient-centered. A trauma-informed framework assumes that everyone has a trauma history. It acknowledges that a patient's life experience is going to impact their perspective and how they're going to engage in the healthcare system, how they're going to engage with us. And it has the potential, by using trauma-informed care, it really has the potential to improve patient engagement, treatment adherence, and health outcomes. Trauma-informed care offers a framework for healthcare providers as well as care in general, right? And really the whole goal is to help avoid this persistent traumatic stress response that injured patients or folks who have experienced trauma may experience. And at a minimum, trauma-informed approaches seek to do no harm, right? Really reducing potentially traumatic aspects of treatment and then the delivery of care to avoid just not having to do that re-traumatization in these different situations. Most standard trauma-informed care model, which most everyone has probably seen, are these 4 R's, again, created by SAMHSA, which states that a trauma-informed approach is one that realizes the widespread impact of trauma, recognizes the signs and symptoms of trauma in clients, families, and staff, responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. Additionally, these are the 6 guiding principles, right, for a trauma-informed approach. Safety in our physical space. Thinking about also safety in our interactions with others. Trustworthiness and transparency. Peer support, including those with lived experiences of trauma. Collaboration. Empowerment, and moving beyond culture and gender stereotypes and biases. And these are some of the models that have used to inform care. Right, so while some of this may be commentary or we may have seen it in different avenues today, we can take a look at how did this idea of trauma-informed care start. So interest in the effects of trauma on the body and brain started after the World Wars. The world was seeing all these young soldiers coming back with symptoms of traumatic stress, right? Things we often think about, such as the hypervigilance, the intrusive memories, the nightmares, the association. There was then even more increased attention paid in the 1970s with the Vietnam veterans. And by the 1980s, PTSD became formally added to the Diagnostic and Statistical Manual, which is used by psychologists and psychiatrists in the diagnosis of mental illness. 1985, the International Society for Traumatic Stress was founded in Washington, D.C. with the goal to disseminate the state of the science as it pertains to the effects of trauma. In 1989, the National Center for PTSD was established to help veterans who were experiencing PTSD. SAMHSA commissioned 2 events in the 1990s that examined the impact of physical and sexual abuse. The Dare to Vision conference allowed women survivors of trauma to discuss their trauma and shine a light on the re-victimization that many of them experienced, especially in these residential or inpatient settings in psychiatric hospitals. A little later, the Women, Co-occurring Disorders and Violence study launched in 27 sites over 5 years and in 2 phases. This study resulted in a set of guidelines for providers to be sensitive to the traumatic experiences of female populations and really brought this attention to the need for trauma-informed care to the entire adult world. In 1995 to 1997, the ACEs study was conducted by a research team with Kaiser Permanente, an insurance company in California, and the CDC, and then published in 1998. And then by 2001, the U.S. Congress and SAMHSA established the Donald J. Cohen National Child Traumatic Stress Initiative and the National Child Traumatic Stress Network, with the goals to better understand child trauma and really aim to develop effective interventions for children that are exposed to different types of traumatic events. So a little more about the ACEs study, because when we think about the research perspective, this was such a pivotal point, right? Doctors, Canadian Canada asked about 17,000 adult participants to complete a physical examination, as well as a survey that asked them to look back and think about their childhood up to about age 18 and consider 10 types of adverse childhood experiences, or ACEs. These included things such as abuse, neglect, and dysfunction in the home. The researchers then looked at the relationship between the number of ACEs and health outcomes. The study found that ACEs were very common. About 2/3 of the population have an ACE score of about 1, at least 1, excuse me. As the participants' ACE score went up, so did their risk of a variety of health outcomes, including poor health outcomes, unhealthy coping style behaviors, negative attitudes towards medical care, increased sick visits and emergency care, reduced preventative care, and reduce overall engagement in healthcare in general. These findings were eye-opening, right? Because some of these things also that were occurring, they were occurring even though even if a person wasn't engaging kind of some high-risk health behaviors, they were still experiencing these really adverse health effects, right? And because of the eye-opening nature of this, there's really this national awareness of this really damaging effect that trauma exposure can have. And thus trauma-informed care really started to become a national priority for study and practice. So what does the literature say about the current state of trauma-informed care, right? Where do we stand? What are some things that are going well, right? Here's an overview of some of the areas that have had the most growth since the start of trauma-informed care, since it started being in the national culture. And I'll touch on each of these 4 areas. So let's start with trainings for trauma-informed care practices. There's a lot of awareness of what trauma-informed care is and how to practice it. Chances are pretty high that you or those you work with have heard of trauma-informed care. You might have heard of its basic premise, the model, the 4 R's, the 6 principles, or even very specifically how to implement the trauma-informed care in your workplace, right? Depending on it, and something I think is incredibly important is people tend to be excited about it, right? Like even if it's required, even if it's part of what we need to do, there seems to be a lot of excitement, doing further trainings, a lot of passion. And what trauma-informed care trainings tend to do, what we found is that they tend to mostly include information about the psychological and physiological effects of trauma, strategies to avoid traumatizing clients and cultivate feelings of safety in your work, tools to develop common language about trauma, and then strategies to prevent that vicarious trauma and improve self-care among staff. More good news is when we think about who is receiving these trainings, we see these trainings on trauma-informed care happening across the board, not just with mental health practitioners. We see an increase in training and practices for service providers for CPS, the juvenile justice system, educators, dental students, and in digging through the research, right? The sports league for traumatized youth in inpatient treatment settings, right? There's trauma-informed care practices around this, how to interact there as well. It's really everyone that is interacting with folks who are coming into our institutions. There's quite an increase in this practice in receiving training in trauma-informed care. There's also an effort to standardize trauma-informed training efforts for police officers and criminal justice professionals. One of the most well-known is the Sansa Gaines Center, which created a trauma-informed response tool for criminal justice professionals. And there are even more options, right? We're seeing these nationwide trauma-informed care trainings for law enforcement and legal system professionals that offer these trainings in person or virtual. We're also seeing this trend in healthcare. A recent study looked at nearly 200 physicians to understand if they had received training on trauma-informed care principles. The great news was that all of them said that they had received at least some training, with 1 in 5 physicians saying that they reported or endorsed that they had received training in all 5. And if we look at these principles here on the right, that's including patient-centered communication and care, understanding the health effects of trauma, screening for traumatic events, interprofessional collaboration, and then understanding your own history and reactions. Additionally, this increase in awareness of trauma-informed care is matching what we're seeing with research. In a systematic review of evaluations of trauma-informed organizational interventions and includes staff trainings, the primary author includes this figure. This demonstrates how common it is to see trauma-informed care in research articles and how this is completely increased over time. So pointed out that in 2014 is when the SAMHSA guidelines on the 4 R's or 6 principles were published. Then we can see even just a couple of years later, it has more than doubled, almost tripled. And there really seems to be this taking of interest in trauma-informed care that has started as there's been this increase in awareness. So, there are more trainings and more folks participating in trainings, but how does that change anything for patients and clients that have trauma? So there's actually been quite a bit of research examining this outcome. Recent research has looked at trauma-informed interventions, and one of the biggest things that they've looked at is that it can absolutely improve attitudes, knowledge, and change across level settings. Many studies have found that training participants, right, by actually being a part of these trainings, they can feel more knowledgeable and skilled after that, and that it can encourage change not only individually, but in the group that completes the training together. And we're seeing this in multiple domains, right? This isn't just mental health, this isn't just trauma-informed care for mental health workers. Really, wherever these trainings are taking place, there seems to be this sense of collaboration as well as this sense of change. So dive in a little bit more. A 2019 systematic review looked at organization-wide implementation of trauma-informed initiatives. 23 studies were included that met criteria and had some way to look at pre- and post-assessment after engagement in the trauma-informed care training. In more than half of the studies, staff knowledge, attitudes, and behaviors related to trauma-informed practice improved significantly when they were looking at the pre-post training. And then most found that improvements were retained at 1 month. Trainings with shorter durations had smaller effect sizes, meaning the shorter the training, often there was a little bit of a smaller change in the knowledge or skills or attitude, but they were seeing that participating is leading to a personal change, professional change in how you're interacting with clients. 8 studies looked at the effects of a trauma-informed organizational intervention on client outcomes. 5 studies found that, again, there are statistically significant changes, although 2 didn't measure client outcomes. And they found improvements across different settings that the staff that participated in trauma-informed care trainings in their work, and they found there was reduced disciplinary office referrals, reduced seclusions in psychiatric hospital settings, and improved patient perception of shared decision making. Right, so really saying by engaging in this care, it has directly translated to their work with their clients. Or this might also be tied to our next area going well, which is this proliferation of specific strategies to implement principles and guidelines that are available across a range of populations. So, right, well, the 4 hours are great, the 6 guiding principles, all of this is fantastic. What's been really helpful and really great is there are several specific techniques that can be used and applied the same day that someone engages in trauma-informed care, right? Past just looking at models or talking about it theoretically to how exactly do I do this today? How do I work with my patient today and make sure to include this new thing that I've learned, right? And so this is kind of a proliferation of these different things. Here's just one, right? Describing how we offer more choices, we change our language. Again, things that require practice to do over and over again, but starting to say, here is how you can be trauma-informed today, right? Research and clinical practice have also published and implemented many more guidelines for how to start incorporating trauma-informed care so it doesn't feel overwhelming or abstract. For example, some specific information that have been given to providers include sitting with patients, providing eye contact, right, allowing them to acknowledge trauma has happened, saying before going through an exam, telling them what they're going to do, asking if there's any questions before just diving into the exam. Well, all of these things might now seem like common sense or quite simple, right? This is because this has been happening over and over again, pushing out these guidelines, making sure we know, hey, here are some very simple ways that can make a very big difference to your patients. The other thing too that we've also tried to stress is that it will actually not be interfering with your workflow. It will reduce the amount of time that you're spending the visit by allowing you to really connect deeply rather than feeling like it's another thing to check off the list. I want to also just briefly point out too, right, we also have frameworks again to keep in mind for trauma-informed care for specific populations. And I think of this one for my specialty area, which is perinatal patients, and how these 8 days again may seem a little bit theoretical, but can be broken down into tangible steps so I know what to do when a perinatal patient is coming into my office. Right, these include things to make sure that I'm checking with myself that I'm engaging in trauma-informed care, such as acknowledging trauma has long-term effects, right? Asking about abuse history and asking about if needs are being met at follow-up. And really, the idea too is that we have these guidelines to really guide and anchor our work rather than feeling like we have to kind of reinvent the wheel every time. And so, thinking about disclosing trauma, right? Not only assuming trauma, but the last thing that has been going really well has been this normalization of disclosure of trauma. So it is much more common in both our culture and our work to talk about specific experiences of trauma. Think back to reading about the ACEs study and how part of what was so revolutionary about it was that no one had asked, right? No one had made this connection between all these poor outcomes in adulthood and childhood trauma, right? Childhood trauma was so often not discussed, or it might have been kind of just there's a lot of shame, a lot of stigma around disclosure. And of course, there can absolutely still be shame and delay in disclosing, but there's much more openness in talking about it than there has been. Part of why this is so important is that the process of disclosing trauma experiences plays such a crucial role in a survivor's recovery trajectory. Studies indicate that initial disclosure, that the disclosure experience, initial one with a person, of course, the first time that they disclose periods, but how they are disclosing and who they are trusting can affect their psychological outcomes, health-seeking behaviors, and overall functioning and recovery from trauma. In 2021, American Medical Association adopted policy recognizing trauma-informed care as a practice that acknowledges the widespread impact of trauma on patients, identifies the signs and symptoms of trauma, and treats patients by fully integrating knowledge about trauma into procedures to avoid re-traumatization. So here's an example of, this is a primary care screener. So this is designed to be implemented into primary care. And this looks at past trauma exposure, well validated and cited by over 1,000 research studies. And really, again, kind of this excellent example of how we can integrate trauma disclosure and PTSD symptoms and asking about it into various realms. So part of why this is so important is there exists a set of beliefs that asking or talking about trauma worsens psychological symptoms. However, strong evidence has shown that these beliefs are incorrect. Right? Survivors, excuse me, studies have looked at the reactions of sexual abuse survivors to being asked about assault-related information in research contexts. And the findings consistently show that the vast majority of participants do not find being asked about trauma histories distressing, nor do they feel traumatized. Not only does directly assessing use history and related symptoms not cause harm, but research also actually demonstrates the opposite, right? They keep on finding that individuals report lower distress as a result of being asked about these topics. Again, disclosing traumatic experiences is associated with this reduced psychological distress and enhanced resilience. So we can talk even more about an example in my area of expertise, which is trauma exposure to PTSD and how it affects pregnancy. We know perinatal PTSD is common. Love it talk, right? But when we think about perinatal PTSD, it is essentially experiencing PTSD during pregnancy, either due to pre-existing trauma exposure, traumatic events, and entering into pregnancy with PTSD, or we can think about PTSD that has occurred because of what has happened during the perinatal period, such as perinatal loss, birth trauma, onset of domestic violence. So we know it's common. We know it has a lasting impact on the pregnant person and their child. And while the American College of OB/GYNs recommends screening for perinatal mental health, most of that focus has been on perinatal depression. However, there's no standard of care for screening for trauma and PTSD symptoms during pregnancy or postpartum period. So for this study, we implemented screening for trauma exposure and PTSD symptoms across clinics in Indiana. We implemented screening in 3 locations across 2023 to 2024. We started with Eskenazi Health, which is a safety net healthcare system serving a large population of low resource as well as racially minoritized patients. Also implemented screening at IU School of Medicine, Coleman Center, which is an OB clinic serving a range of patients in downtown Indianapolis, as well as Logan Park Memorial Hospital Women's Health Center, which is in Logansport, which I think is not too far from here. It's about 90 minutes north of Indianapolis, and is in one of the most disadvantaged census tracts in the state. At all locations, team member distributed a screening packet to all English-speaking pregnant adults to assess PTSD symptoms, sometimes along with others, but sometimes there were other mental health measures included as well. Our thing was asking about trauma and PTSD. We also asked if folks were interested, if they said yes, and heard more about treatment or either about research studies they would be eligible for or clinic where they could receive care. So we utilized 2 validated PTSD screens. Right here is the first one. This is just the primary care screener I showed earlier, just going up a little bit more. Right, it first asks, have you experienced trauma? And then if you have experienced that, yes or no, in the past 30 days, have you experienced these, are covering all the different kind of clusters of PTSD symptoms, yes or no. A score of 3 or higher indicated probable PTSD. For Eskenazi, we utilized this 6-item abbreviated PCL civilian version one. Participants only had to answer about PTSD symptoms rather than also endorse trauma exposure, and a score of 14 or higher indicated probable PTSD. In our rural screening location, our team was able to screen 334 patients with the 5-item screening measure. And as you can see, over half of rural screening locations endorse trauma exposure, and about 1 in 4, so on the trauma exposure, and then PTSD is reflecting that of those who said, yes, I've experienced trauma, about 1 in 4 patients scored above clinical threshold for probable PTSD. We only had a short screening period for our low-risk clinic. There were 24 patients screened at our low-risk at IU School of Medicine, the Coleman Center. And there were 7 patients that endorsed trauma exposure, with 2 of those 7 that scored above the clinical threshold. And then in our high-risk clinic in Indianapolis, there were 92 patients who were screened with a 6-item screening measure, and there were 19 patients, or 21%, that scored above the clinical threshold, again indicating quite a high rate of PTSD. To circle back, right? Because not only just identifying trauma, but what happens next when we think about trauma-informed care. We asked participants in our largest sample, the rural sample of Logansport Memorial Women's Health Center, for feedback on what was it like, right? We gave you this screening questionnaire during the prenatal visit. What did you think about it? They mentioned that they felt comfort, right? They completing the screening, they trusted the team, they trusted the environment. They described talking about trauma. Sometimes it can be momentarily uncomfortable, but that was ultimately a positive experience because now their providers knew something about them. They knew something that could be impacting their prenatal experience. Right? And it also wasn't safe to provide every answer. We've gone through different iterations of looking at qualitative interviews. Thinking back about what participants have told me, right? One has, I don't remember one describing how they realized by answering yes to the questions that they needed some help and actually spurred them to reach out for some help, as well as another who said, I've noticed that, said, yes, I don't want to talk about it, but I know that they've asked, and if there's somewhere that I need to go, that this would be an option. So what we took away from this was, first of all, that we screened a large volume of patients, over 500 women across 12 months, and we found quite high rates of trauma and PTSD, higher than expected from the literature, and across all different clinics and patients and across Indiana. And importantly, right, pregnant women were willing to complete this screening about trauma and felt that being asked about it in this clinical setting was helpful and validating, right, adding to this trauma-informed work that we want to keep doing. So that's great, right? So while all of these good things are occurring, this brings us to there's areas connected to trauma-informed care that we need to improve. Okay? Again, we'll talk a little bit about all of these areas. And we really think about this kind of what come in on these four, right? Follow-up assessments for trainings, consistent next steps, following disclosure, burnout, and systems level change. Right. The first that I want to talk a little bit about is how we're assessing change following trauma-informed care trainings across the board. So the first area of growth that we need is more long-term assessment and evaluation of trauma-informed care training. We know, right, that even personally, right, we go to a training, we feel really invigorated, we're really excited to do that, and we can, personally what it's like. Personally what it's like that we are ready to make some change. But what we're not seeing is that we don't have a lot of data on what happens after, but not just us, but everybody. All right. So even though we know that there are changes, right, we don't know what happens over time. A lot of the studies that they have done have looked at only changes immediately after, right? Like, hey, that same day, you have your change, right? Even if you have every intention to, I'm going to go back, I'm going to go to my workplace, I'm going to do all of these things. It can be really hard in a few hours, right, for things to dramatically change. As well as, right, when you look at those, when you're getting that assessment, it might be for, CEs, or it might be for your job, or you can't say your course was completed until you did that. Right? So when we think about, again, thinking of this review that we looked at, in 7 of the studies, the review post-tests were only administered immediately after the training. There was no indication of whether these changes in attitude lasted for a meaningful time. And what we do need to know is, what is trauma-informed care, kind of that almost, what is this looking like a month down the road, a year down the road, as well as not just for me, but what about for everyone? How is this impacting everyone's behavior? So another issue is how the trainings are being evaluated, right? Again, we look at this review of this 23 studies, trauma-informed care. 12 of the studies are using questionnaires that were just developed by the people who are doing the training. So of course, there not only may be a bias in what is being learned, but also there's not an ability to standardize. We don't realize, hey, in this training you're getting this, in this training you're getting this. There's no way to be like, this is what we know we need to do, and we need to have this across different trainings. And so there's often not been one consistent tool that has been used to really do this comparison. And lastly, a lot of times multiple trauma-informed organizational intervention components are moving at the same time, which is wonderful. And of course, we want to maximize time, but we don't know which of these components is really the one that is driving the change. And can it be distilled even more so we can reach more people, we can repeat it, right? It can really be, we know what the impact of ingredient is. So how do we change this? So first step is to change how we're thinking about evaluation and trauma-informed care trainings, including meaningful, short, medium, and long-term process and outcome measures can really provide more information. There is a measure. This is called the Survey for Trauma-Informed Systems Change, pictured here. This is the first psychometrically reliable and valid tool that can help professionals, and it's been measured and utilized by multiple different systems. lawyers, law enforcement officials, physicians, mental health care providers, educators, and many others, right? And it really has evaluated culturally responsive trauma-informed practices. Using this measure multiple times after trauma-informed care trainings, right? Is this thinking about this kind of change could really help us to better understand how different trainings are affecting folks and really be able to kind of distill what is it that we really need to make sure we're including. Is there any extra stuff that would be nice to have that isn't like, hey, we've got an hour, this is what we really need to do. We've got 3 hours, this is what we really need to do. And often we focus so much on the delivery of the training, but that assessment before and after is really crucial to better understand how do we make sure that this is something that we can include in the So also in general, right, when we think about where is the research going on trauma-informed care training, this is kind of touching us a little bit as well, but what is the minimum duration, right? Do you need 3 hours? Do you need 3 days? What is it that you need to be able to say that you are trained? What is the content that is most important to include, right? How much tailoring is needed? Does it need to be different when it is for lawyers, for mental health care professionals, police officers, right? How much tailoring needs to happen? Does it need to have tailoring at all? And then what are the most important defined outcomes? Are we measuring the same things? Are we measuring the same, are we looking at and collecting the data to understand these are how clients are changing? And then thinking about next steps following trauma disclosure. There can be a lot of inconsistency and confusion of what to do if during delivering trauma-informed care, trauma disclosure occurs, right? Sometimes when we think about trauma-informed care, we think that we're going to try to make sure the person is comfortable. But one, what if this person has actually now said, I have experienced this, and what do I do? And providers say that one of the biggest obstacles to assessing trauma exposure is how to help their patients if trauma exposure PTSD symptoms actually are disclosed, right? And even sometimes, this is often when I talk about all providers, even with mental health providers, we might be think of the doorknob statement, or we think of we might have been working on something else, and all of a sudden, sometimes I think like there's a bombshell. And so recent studies have found that primary care providers fear that there isn't time in the visit to address trauma properly. Sometimes not be addressed at all. They may feel unprepared to deal with their patients' issues or fear that they might actually cause harm when discussing with patients' more complex issues. There was a review published last year on primary healthcare practitioners' perspectives on trauma-informed examinations and looking at patients with a trauma history. What they found is that providers were more hesitant to conduct examinations of patients with a trauma history and navigate tension between addressing patients' immediate needs and then this underlying experience of trauma or violence perpetuating their medical issues. We're also seeing this in mental health care workers. A review found that while many professionals acknowledge the importance of asking about trauma, there's little evidence of widespread routine inquiry during mental health assessments in settings, even settings such as psychiatric hospitals, emergency departments, and community mental health centers. Areas that all the places that should know if patients experience trauma, we would think that would be them. So part of that difficulty is even if a patient discloses trauma and asks for help, such as for a provider to make a therapy referral, often there is a feeling that it will not be sufficient. And in a lot of places in this country and state, there's just not enough mental health providers to help those who have experienced trauma. As of December 2023, more than half of the US population, or 169 million people, live in a mental health professional shortage area. Further, most psychologists are not taking new patients. The national wait time can be closer to 1.5 months, which is not what you want to hear when someone is open to treatment now or needs help right away. This is even worse for rural patients. Sorry, pause for 1 second. So when we think about rural patients, right, when we think about shortage of the shortage of providers, they may be not only experiencing that there's less providers available, they can have the experiencing personal, like on a personal community level, sometimes there's even more trauma exposure. They're often more impacted by limited availability, access, and acceptability of mental health services. And over 60% of rural Americans experience insufficient or no access to mental health care. So even if they're able to see a provider, there's often additional barriers such as stigma around seeking treatment, medical treatment costs, and lack of transportation. And so part of why this is so important is because often the thought is you disclose trauma, we'll get you into therapy, everything will be fine. But this is not a reality first of all, mental health is not a reality for many folks. It's even worse for rural patients when we think of who is in the state of Indiana. That's quite a lot of us. So what can we do? Part of what we can work to change is to spread the message that everyone can understand that trauma-informed is not the same as trauma therapy. There seems to be a lot of fear that whatever interaction, if someone discloses therapy, all of a sudden this now has to become a psychotherapy session, right? And if you remember from earlier, 60 to 70% of adults will experience a trauma, but the rates of PTSD are about 4 to 10% of the population. And that means most who have experienced trauma, most of those who have experienced trauma do not necessarily need treatment or help. What they need is a change in culture, right? That if they disclose trauma, they are believed that trauma happened and that might have an impact on their life. This can lead to discussion or resources or options if they need it, but above all, it will create a safe place for disclosure that can help them to not feel alone. And so really wanting to focus on too that like if this is this universal acknowledgement, and a lot of us in this room are doing this, but really trying to spread the message so that anyone who is encountering someone who might suppose they have trauma to know that what they really need is to be heard, to be believed, to have some of these statements, right? And again, here are some helpful responses to think about how we can spread that message. And again, I know many of the folks in this room are doing this, but how can we get that message out that when it's disclosed, let's meet it with belief, with acknowledgement that it had an impact on belief. So another area we need to grow is provider burnout, right? There's a variety of trauma afflictions that we may come across when working with traumatized patients, right? And we acknowledge that working with these patients can be difficult. There's a lot that can happen. There's a lot that can, even when we love this work and are passionate about this work, it can take a toll on us, right? We're witnessing, we're validating, we're seeing what people are going through, and it can impact us in a variety of ways. We think of secondary traumatic stress, where we almost are feeling some of those traumatic stress symptoms ourselves. Vicarious trauma, almost an accumulation of kind of witnessing trauma day in and day out, where it feels like it's really affecting us. Burnout, where it's just kind of not having the support you need for the support that you need for doing the work that you do. And this can be not limited to one profession. And compassion fatigue, right? Kind of after so many stories, it's almost starting to affect your own worldview. And then moral injury, right? Sometimes we work with patients where I think of like wanting to work with someone who doesn't have insurance and we know they need care, and yet we're not able to help by seeing them and not being able to engage in care in the same way. Just this feeling of like something falling outside of your values or beliefs. These are common and seem to almost be growing with, right? When we think of disclosure trauma is more common, and we're running into more folks who are willing to talk about trauma, how it's like it's also affecting us as a workforce. So when we think of next steps, the most important thing is to think of this shift from me to we, right? There's a lot of guidelines of how we can take care of ourselves, but there's been so much emphasis on how you take care of your burnout versus we really need to think about how can this be our entire system changing to take care of us, right? We're providing the care, we're trying to reach out and help those that are afflicted by trauma. How are all the systems that support us also supporting us around burnout and recognizing the hard work that we do, right? This includes this change for healthcare organizations, health insurers, friends, families, communities, and just really when we think about where do we need to go, how do we have more of that emphasis on this is not just me making sure I'm taking care of myself and doing self-care, but how can I make sure that my team, we all take care of each other, but also our system cares and takes care of us. Which brings us to the big one, right? The systems level change. And this is the most difficult one because while many of us may be passionate about the trauma-informed care, there may be lip service for trauma-informed care, sometimes we're not really seeing that change in the system. And there was this group that, led by Stillerman in 2023, that did a scoping review that looked at the literature from about 2015 to 2020, when trauma-informed care principles and guidelines were implemented, and looked to see how did systems change, right, beyond just return on investment. And so some of those findings, what they found was there wasn't a lot of, there might have been one component in the effort. There might have been some education, but it wasn't like they were changing their workflows. The evaluation was surface level, how many participants came, and there was no plan for the entire organization. And so while this can be disheartening, right, I feel like this seems to be the areas that need the most change, right? The burden for transforming trauma-informed care at the systems level cannot be on one person alone. And it does often feel like the people that want to do trauma-informed care are the most passionate about it, but how do we transform the system, right? How do we keep pushing for that change? Because it cannot be only the practitioners. We think about government, insurance companies, and administrators, right? Everyone that needs to be investing in a way that it is something that we can continue to do, especially like some of the front lines that are really delivering the work. So I want to very briefly talk about a case report that one of our research studies about what is going that kind of demonstrates what's going well with trauma-informed care, and then working to fix where we can grow and push for systems change, especially around birth trauma. So very quickly, traumatic birth experiences are very common, with 1 in 3 and up to 45% of women reporting that their birth experience was traumatic. And to define a birth trauma, to give you a definition of that, essentially it's something that's characterized by overwhelming negative emotions and distressing reactions, leading to short or long-term negative effects on a person's health or well-being. There's a lot of damaging consequences associated with birth trauma, especially mental health difficulties, problems with romantic relationships, having fewer children than you originally wanted, and then that downstream effects on the children and the parents. So through this common experience, research is really looking at this high amount of endorsement of birth as traumatic. And one of the risk factors most consistently associated with the traumatic birth experiences is poor communication with medical providers. There was a study of over 2,000 women who had experienced birth trauma, and many of them believed that the trauma could have been reduced or prevented if they had better communication with their provider and actually talk with them a little bit more. And as you can see from this list of all of these named reasons from all of these individuals, the ones that were the highest are the communication and the explanation. And because there's of course obstetric and medical risk factors associated with traumatic birth experiences, but this lack of trauma-informed communication with one's medical provider is this consistent, robustly predicted risk factor for an individual to perceive their birth experience as traumatic, really indicating this intervention, this potential for intervention. So given this high prevalence of birth trauma, we wanted to see how many of our patients and providers are perceiving their birth as traumatic. And is there a conversation that's occurring between patients and providers? So we asked patients pretty quickly after they delivered, between 0 to 3 days, if their birth was perceived to be traumatic and the occurrence of post-birth conversations. So, and then here's just very quickly, we asked patients to assess their trauma using the DSM-5. Is this something considered traumatic? We also asked them for their experience, what they thought about their hospital experience. Questionnaires were then sent to RedCap to their providers that were asked the same questions. And so what we found, right, not information, but what we found in our sample was that participants had a mean age of 28, mostly multiparous, mostly 6% white, 25% black, and 9% Latina. And what we found were pretty high rates of birth trauma, 37% as high as that. We broke this down to who endorsed birth trauma and those who did not. For those who endorsed having traumatic birth, they said that 7 out of 10 had a debrief after their birth. However, their providers did not also see it as traumatic. Only about 40% also said, yes, that person experienced trauma. For those that did not endorse having a traumatic birth experience, it was even better, right? They felt heard, but their providers also, again, when we think about this, their providers were looking at them and saying, yes, that was birth trauma. So about 16% received it, even though the individuals did not. So what is this telling us, right? That there's a big discrepancy. So what we wanted to do is ask the questionnaire, what was it like to actually fill out this questionnaire and have us try to work to change this system? And I know these slides are really good, people want to include a lot of information. What was really shocking to us was no one found it person. This was hours or days, 1 to 2 days after the experience of birth, going in, asking them, what was it like to be asking, did you fear for the life of your infant? Did you feel fear for your life? Did you fear for these, was this traumatic? And people answered, but they also found it a positive experience. We asked if there was a way to make it more comfortable, right? Saying, did you think you would die? Did you think your infant would die, right? And again, there wasn't a way to make it more comfortable. I'm glad that you asked. We were worried it could be jarring and upset, and that's not what we found. There was also a lot of relief and gratitude, right? A few of the participants asked that they acknowledged there wasn't anything that could change their medical complications, but they really liked to check in. Again, also asking, most of these women had experienced birth trauma, and they were still saying, right, it was helpful to be asked, and didn't change, it didn't really change the postpartum experience. Answering these questions were not negative, but what it was a positive experience. So why I bring it up, again, very briefly, is we really wanted to target a powerful time point to think about, can we ask, assess, bring in resources, and then work to change? Because now, having known this discrepancy with patients and providers, we also have the chance to try to impact the workflow. And that's where we're going next, is working with the whole hospital to say, how can we change how we are having providers and patients talk to each other in this time period, and how can we offer more interventions? Final thoughts. We want to continue to build on what we're doing well, right? Can we continue to participate in and offer trauma-informed care trainings? Participate in surveys, right? The more that you're asked to evaluate a survey, fill them out so we have more data, we can make more conclusions, and continue to normalize this trauma assessment and disclosure, as well as press for change, right? It's not up to any one person, but how can we use standardized measures to examine these changing trainings? How can we spread that message that trauma-informed does not mean you're now a trauma therapist and you're now doing trauma therapy, but you're really working to make sure that when disclosure happens, there's a good response to it. And how can we, really importantly, push for systems change? We can't be the only person responsible for integrating trauma-informed care across the board, so that we also, right, and really trying to make sure, burnout, vicarious trauma, all these things are real. How can we take care of ourselves and our communities and make sure we're not in the loop? With that, thank you so much.
We don't really have time for questions, but maybe, I wonder if, thank you for, it was very comprehensive. I don't know if there's a way for people to get slides, because it's a lot of information to digest.
Yes.
So is that something that we can make available to people?
Absolutely.
Okay, that's fantastic. Thank you so much for being here, Michelle. And we have 10 minutes before our first panel starts, so thank you very much. Yes, I think that we don't have time for Q&A. We can't do it. Oh.
Momentum here to get us started. All right. My name is Shinita, and I am the manager at the Source. And wow, hearing Dr. Miller share about how long we have come along with trauma-informed care, unbelievable. And as Anna mentioned, she was a young home visitor learning about trauma-informed care. I was an itty-bitty social worker at that time, learning about trauma-informed care, and just a simple fact of shifting the perspective to what happened to you was just profound. So with that, today I'm very pleased to moderate our first panel looking at organizations striving for trauma-informed care. And we get to hear the inside scoop from an organizational level, what it means to be trauma-informed care. So be prepared for it. With that, I would like to introduce our first panel. Dr. Rose Gillen is a family physician and medical director at the Center for Healing and Hope. She has been practicing medicine in Goshen for over 30 years. Her past work experience includes serving as medical director and family physician at Maple City Health Center and as coordinator of medical services at Oakland Psychiatric Center. Dr. Gillen was born and raised in Puerto Rico and understands the complexity that culture and language brings to healthcare. She strives to help her patients feel safe and heard at their medical appointments. One of her priorities is to partner with them in discussion about lifestyles and mental health and how this affects physical health. Talk about continuation from our previous speaker. When not practicing medicine, Dr. Gillen enjoys gardening, reading, and going for walks. Self-care, she just embraces it all. So please join me to welcome Dr. Gillen.
Good morning. Can you hear me okay?
Yes.
Okay. Before I started, I just wanted to say that coming to a group like this is just an encouraging thing for me. I know that the world can feel really dark and chaotic and hopeless at times for different reasons. And one thing I heard was from Mr. Rogers, who said that when the world feels dark and chaotic and bad things are happening, he remembers what his mother taught him, which is to look for the helpers, that every time something bad happens, look for the helpers, and that brings encouragement. And so when I come in here and see the group of people, I think, yeah, often I mean, right now, things seem dark and chaotic and hard. And here we are, a group of people working together, and that's just an encouraging thing for all of us. So I am the current medical director at the Center for Healing and Hope, and I've been there 3 years. And for those who don't know much about the center, it was started a little over 25 years ago, and it was an outreach of St. John Catholic Church in Goshen, and they were aware of so many people that were uninsured and just didn't have access to healthcare. So they started a clinic just several hours a week at the church, and then over the years it moved to the Window, to the Lighthouse Church, to the Plymouth United Church of Christ, and then now at our current location on Lincoln Avenue in Goshen, which is a permanent location for us. But over the years, it went from very tiny, just a few hours a week, with volunteers that just had a heart to provide care for people, to what we're doing now, which is we now have paid staff. We still have a lot of volunteers that join us and help in a lot of different capacities. And we now are open Monday through Friday, not just a few hours a week. And we provide primary care for people. We, as part of that, chronic care, acute care, preventive care, screenings, that kind of thing. So we have two focuses right now. One is the medical side of it, and the other one is our immigrant advocacy, where our immigrant advocacy director partners with the community, different organizations in the community, to just help connect people to services. So I have 3 questions to answer, and the first one is, what organizational successes have you had implementing trauma-informed practices? And I'll say that as an organization, we have not had structured trauma-informed care training at this point, but most of us have been trained in trauma-informed care at other locations or on our own. So we are very, very aware of the trauma that is present in so many of our clients and staff members. Our current patients include uninsured and immigrant, a lot of uninsured people, a lot of immigrant people. It's not all immigrants, but most of them would be. So we have a lot of vulnerable people that we see for medical care. And we know that all people have the potential for having had trauma in their lives, no matter who we are. But there's unique aspects to immigration trauma, and we see a lot of that. Some of that includes sexual abuse, physical abuse, deprivation, fear, and dehumanization from authorities. And so we have a high level of patients who have experienced this type of trauma. So what we've tried to do is put things in place that will help others feel more welcome. So some of these things are, the first one and the most important is to be aware. We try to make sure that all of our staff members are aware that trauma informs people's behavior. So when people don't show up for appointments, or when people are hostile, or people don't follow instructions, or people lie to us, or people say, yes, I'm taking my medicines, but they really aren't, that we understand this isn't because they're bad people, but they've gone through some things, and this is the way they can manage life right now. So being aware of this, being aware that by the time immigrants arrive in Elkhart County, they've been through the mill. And when people have been through trauma, they're often grieving a lot of losses also. And when we are grieving, we just don't think in the same way that we do when we're not grieving. So just being aware that the way people are functioning is probably not their best right now because of everything that they've been through. So when we remember this, we're more compassionate and more understanding and more supportive. So the first thing we try to do is just be really aware of what is going on in our patients. We have also tried, sorry. Okay, I apologize. These are not my slides. I just hit them by accident.
You know, don't worry about it.
Yeah.
I'll
Yeah.
when she's done, I'll go back up.
I will not touch that. We have made sure that all of our front office staff and our medical assistants and our staff nurses are all bilingual in Spanish, so that patients are able to communicate freely when they come in, when they leave, and when they're in their appointments. We do have some providers that don't speak Spanish, but we have interpreters for them. And some of our interpreters are on staff and some are volunteers. We really rely on our volunteer interpreters to help out with these appointments. It's the number of people that have said to me, you don't know how wonderful it is to be able to speak in my own language at these appointments and understand what's going on. We try to hire caring, compassionate staff who are able to respond appropriately to the patients that end up being a little more difficult. Last week, Friday afternoon, late afternoon, a man came in and he was very upset about his bill. And he had been drinking a little too much, we could tell from the odor. And he just over and over and over was arguing with our receptionist about his bill and why was he being billed for these different things. And I was listening to this from the room next to that, and just hearing how she just over and over just explained it to him patiently, kindly. He asked the same questions over and over, she answered them over and over, and eventually he calmed down and they were able to work something out. But I've been in other situations where a person like that walks in and they're scolded right away and it escalates. And so just hiring people and making sure people are trained to understand that how the conversation goes depends a lot on how we treat people.
Yeah, come on.
We've made the decision to have 30-minute appointments for our patients, and this is somewhat unconventional. And in an insurance-based practice, this is sometimes not possible to do, or at least more difficult. But we feel we need that time, especially for the providers that need an interpreter to help. We need the time to connect with people, to be able to sit with them, to not just say, you are here for this, this is what we're gonna do, goodbye. But we sit, we talk, we interact, we engage. Because part of what we are trying to do is build trust with people. And we can't build trust when we're just trying to rush people through. And so we have done that. We screen for depression and anxiety so we can address those issues if needed. We have a volunteer bilingual therapist that comes once a month for one-on-one therapy. And she explained to us when she came that once a month is not a lot of time. And she can't do continuous therapy with them like she would in her when she was employed. But she trains them in skills. She will meet with them once and they talk about whatever is the highest priority. And then she gives them some skills to use. And then she allows them to schedule as they feel the need. They can come back next month, they can come back in 3 months, but she gives them some tools to start. And we've had a lot of good feedback about that. We also have a volunteer bilingual psychiatric nurse practitioner that comes once a month to help us with our patients that need a little bit more support in terms of the medication management for psychiatric conditions. And again, once a month isn't a lot, but he explains things clearly to them, they understand, they follow up with them. And he explains to the other providers what's going on in case anything's needed in between, and he's available if we need him in between. But those two volunteers are just invaluable in our care, or in our ability to provide care. Our staff providers are very aware of the trauma that our patients have experienced and are willing to take the time to listen, treat, and refer if appropriate. I hear story after story. I don't see new patients much anymore. Mine are more established, but our other providers see new patients all the time, and I hear all their stories. And often their patients are in tears in the office because they've been able to build that rapport and just build that trust with them, which is just wonderful. It's hard, but it's wonderful. We have a bilingual social worker as our immigrant resource coordinator who's available to meet with our patients and with other community members to help them connect with community resources. And she has made a lot of connections with other community partners so that she can refer people to things. We don't have all the resources that people need, but she's able to connect them. She also does advocacy work and listens to story and tells stories. On the staff level, we've addressed situations with our staff that were contributing to inter-staff trauma. Not ignoring those things, but trying to deal with them openly so that we could improve that. We've tried to have yearly staff retreats. We strongly encourage our staff to take care of their own mental health needs. We've been doing Lenten meditations. We tried to do exercise, but we kind of fell off the wagon on that. We set health goals. We try to have fun together. And we even got a little couch that we put upstairs and kind of put room dividers around it so that people have a place to go. Staff people have a place to go if they need to lay down for a few minutes. Or just get away from things for a little bit. And then challenges to implementing trauma-informed practices are the lack of readily accessible bilingual mental health services in that area and not having a full-time mental health provider on staff. Financial challenges both for patients and also for our organization, and then time constraints as we get everything done. One more minute. How do we know what has been successful? Basically, when patients are open with their providers during their appointments, when we see signs of patients learning to trust us, when patients are receptive to the recommended treatment, when patients agree to therapy and pursue it to the best of their abilities, when their screening, PHQ-9 and GAD-7 scores improve, and when patients give us direct feedback with appreciation and gratitude. One of our patients brought a big bouquet of flowers several weeks ago, and with a little note just thanking us for their care. So that was very, very helpful. And I'm just gonna finish one quote. Our pastor recently shared this at church. Evil is large, cosmic, organized, subtle, pervasive, and real. And love is also cosmic, organized, subtle, pervasive, and real. And I think that the work we do is our way of continuing to fight evil and spread love. Amen.
All right, Lisa is gonna do her magic while I move on to the next introduction of our next panel. Is my dear friend, Darlene Radcliffe, who is the culture and value champion at CAPS. She is a licensed clinical social worker whose work has focused on helping young children and their caregivers recover from trauma and build resilience in the context of young children and their caregivers, as well as in building deep, caring relationships and the adventure of playing together. She's all about playfulness, and you can see it in her slideshow later. Darlene has a long history of working with children and families and was a play therapist for 20 years. And she has been working primarily with children experiencing trauma. So the magic is about to unveil. Maybe we need a drum roll. We
all remember the first slide, which is a cake.
Yes.
We were so well prepared. We had it all ready to go.
Okay, I'm gonna go ahead and get started. Boy, am I excited to be here. I've got my heart going here with this technology stuff, but we're just gonna go ahead without slides for now. So I'm really excited to talk to you all though about my experiences working with several different organizations that were on a trauma-informed journey. Thanks so much. So I've had, in my journey, I've worked with the Center for Homeless and Hope Ministries in South Bend, and then also Raise of Life in South Bend, Oak Run, and then most recently CAPS. And for me, the metaphor that works the best, I love metaphors, and the one that works the best for me in describing an organization becoming trauma-informed is that of several ingredients mixed together over time in good measure, baking right into the culture and values of the organization. So I think you saw the cake, that I had on the slide before. And the result of baking trauma-informed values and practices into an organization's culture is just like that delicious looking cake, something that everyone can partake in and savor. So we begin with that cake in mind. So the next slide had, if you can imagine, the ingredients of the cake. So there were eggs and flour and butter and baking soda and salt and everything. And those really are like our trauma-informed principles of SAMHSA. So safety, trust, peer support, collaboration, empowerment, and humility. So when you blend those together in an organization, these ingredients completely overlap each other, just like those the flour and the eggs and the butter do in a cake when they're baked. So let's pretend for a moment that we could slice into that delicious cake for some examples. And so the next slide was a lovely view of a slice. If you can imagine taking the cake and looking right down on top of it and then having it sliced into thirds. So in each of those three slices, I partnered together two of the trauma-informed principles as they relate best to the experiences that I've had. So we'll cut into the first slice, and that is trust and humility. So a trauma-informed journey in an organization starts really with the leaders. And so many of you here are those leaders that are comfortable with making it safe to be vulnerable. And so here's some specific examples of behaviors that I've seen leaders do in those organizations I mentioned that model trust and humility. So they led conversations about complex situations in which they admitted they didn't have all the answers. Humility. They invited diverse staff from different cultures and backgrounds to join in conversations and offer their perspectives and their wisdom. They read a trauma-informed mission statement in key meetings like staffings to ensure that everyone in the meeting would view individuals, clients, and staff both through those trauma lenses. So there was a slide of lenses, but I also brought my own with me. So these lenses allowed us to see each other and our clients through those loving trauma-informed lens that Dr. Gill spoke about too, the love that we bring to our work. And so everyone then was held accountable to share those lenses. If somebody sort of forgot their lenses and they might have been more inclined to be blaming or thinking about labeling possibly a client instead of looking at their behavior, another staff person could share their lenses with them. Other leaders I've had strengthen trust through transparent communication, especially in tough times. So for example, by sharing clearly and honestly about funding challenges, we all, that's a very common thing that we struggle with, and about what staff could count on, as well as what information leaders did not know, and inviting staff to ask questions and having that open trust and transparent communication sharing. And this made a really difficult and painful situation tolerable
and it minimized trauma due to job loss and changes. So those relationships always buffer trauma. And lastly, I've been blessed to work with a leader who created a work environment where it was safe to make mistakes. And so she embraced the acronym OOPS from Conscious Discipline, which stands for Other Opportunities for Problem Solving. And she often asks, okay, what have we learned that we could take with us from this experience? And as a result, staff felt safe. They trusted each other and they excelled. Those are all trauma-informed examples. And then training, really focusing on training. Leaders who model trust and humility embrace training and follow guidelines like thinking of trauma-informed care as a journey, just like cultural humility is a journey. You never really get your black belt in those things. You're always learning, and you don't arrive at a specific destination. It's a continual, lifelong process. So basic trauma training was provided to every staff, like a trauma one-on-one training, and then leaders participated. They were there, they were in front row, and they were asking questions and modeling how do we build trust and make ourselves vulnerable here, and even question some of our practices and learn new ones. And then after that basic training, ongoing trauma-informed topics, like specific things, would be presented at regular intervals to keep the conversation going, so that it didn't die out. And we continued to look, well, what about this? Let's look at this group of people that we think are very vulnerable, and how can we help them? And then there were refresher trainings that were done very intentionally on a regular basis, so quarterly or annually. Those were done. So ready for another slice of cake, imaginary cake? We'll slice into safety and empowerment. So becoming trauma-informed as an organization has been compared to many things. Like people say it's a marathon, not a sprint. Or they say it's like turning the Titanic to change an organization and become trauma-informed. Or they'll say, this is I think my favorite, we're building the plane while we're flying it. So these are all really difficult things, and they require every team member's effort, and most of all, they take time. So leaders who embrace that safety and empowerment principles are focused on supporting staff long-term. In those organizations that I work with, leaders plan for providing psychological first aid when staff were exposed to trauma, when they had high compassion fatigue, or when they experienced burnout. And so those are things in their first aid kit, things like empathy, compassion, support, active listening. And leaders in these organizations also really supported self-care, so they encouraged staff to say no when they needed to engage in reflective supervision or consultation, and talk about topics like the best way to transfer clients if you need to, or end with clients. How do you maintain that work-life balance to be healthy? How do you encourage staff to increase their capacity for self-awareness and challenge some thinking in a safe way? And then viewing all clients and coworkers through those lenses that we all need. So the results of the leaders learning into safety and empowerment like this is that, in my experience, staff stayed. So that retention that we know is so important was really there. So we talked a lot about data with Dr. Miller, and so there were some good experiences that I had with data gathering. And then the trauma-informed piece of that, I'm not a data expert, but the trauma-informed piece of that was that the data was then shared back with the staff, and they could see their own words up on the screen. Like if they had quotes, they were not identified by their name, but they could see that I was heard. So being seen, heard, and understood. And the last slice of cake that we're gonna take a bite of here is peer support and collaboration. And so this is all about leaders who work hard to build a culture where everybody knows in their gut, kind of like eating a delicious piece of cake, that there's a place for them at the table. And so actively nurturing a safe environment for conversations to occur, asking staff to share their concerns about physical safety and felt safety, and then responding to those concerns with actionable things, making team building a priority, providing regular opportunities to celebrate successes. We all need this. This is very trauma-informed. And then thanking staff often for their contributions. And I have one leader that I work with who makes a team message, like a connection with each staff person every day. And it doesn't take a ton of time. It's maybe 2 sentences, but it's a point of connection that says, I care about you, I want to know you, and I'm glad that you're at the table. And finally, I do not want to end without talking about playfulness, that we all really need that ability to play, because when we're playing, we can be safe, and when we are safe, we can play. And that's trauma-informed. So lastly, successful things that have happened in these organizations is that they developed trauma-informed champions from every single part of the organization, including marketing, IT, food service, maintenance. Everyone came to the table and build SMART goals that could be tracked, and that could be actionable things that put into where the rubber meets the road. That's another one of those things when trauma-informed care really made an impact. So the icing for our cake might be the best part, because it's all about the choice that leaders and their staff have made to be trauma-informed. And this is also really important during hiring and onboarding processes. So just those organizations really made it clear that we are going to be trauma-informed here. We've chosen that, and so when you join us, you'll be signing up for that. So it's very transparent from day one, from even before day one. Being trauma-informed is a choice that really comes from the heart, and it works best if the hearts of staff across all departments of the organization are genuinely aligned. Thank you so much for making the choice to be here today.
Unfortunately, we do not have time for questions. However, I do have a quick question for the panels here. As you reflect on your trauma-informed care journey, what is one word, hashtag, or motto that you want to motivate the audience today? Cool. Okay.
Hashtag endless possibilities.
Hashtag endless possibilities. All right. Well, thank you. Thank you to the panels.
Good morning. I'm Linda Raven. I am the Pro Bono Counseling Project Coordinator for Mental Health Awareness of Michiana, and welcome to the panel on learning from lived experience. Today we have Jose Elizalde and La Sierra Sharks on our panel, and Jose will be speaking first. Jose Elizalde is the Youth Mental Health Coordinator for the Source, Elkhart County System of Care. Jose is a bicultural, bilingual, Spanish and English, professional with extensive and diverse work background. Born in Mexico City and raised in Chicago, Jose understands the Latino immigrant experience in the USA. Jose has been an ordained minister, educator, caseworker, director, career coach, academic advisor, and community organizer. Jose received a BA from Goshen College and an MDiv from Trinity Evangelical Divinity School. Currently, Jose is a certified Gallup Strengths Coach and holds a DEI certification from Cornell University. Jose is active in his community and serves as a Goshen Community School Board member. Thank you, Jose.
See, I was trying to think if I want to hide behind the pulpit or not. Can you all see me?
Yes.
So today I'm going to talk about things from my personal experience. And I want to say that clearly. It's from my personal experience. I'm going to talk about mental health and my experience with mental health as a family member, and how I interacted with systems. As you know, I was born in Mexico City. I was a teenager when my family decided to move to Chicago. So I finished high school in Chicago. I came to Goshen College in 1990, and then I went to seminary, and I lived in different places, Harrisonburg, Virginia, Houston, Texas, and so on. My first experience with mental health happened through my dad. My dad seemed to me, he was like a workaholic. He seemed to be very busy all the time. His employer in Chicago, which is the candy factory Tootsie Roll, loved him because he was willing to work on weekends. He was willing to work holidays. He was always working. And, you know, if in my family, hard work was rewarded, was fine. But he was also always in a bad mood, always stressed, always seemed to stress about anything. He was afraid to be stopped by the police. He was afraid of La Migra, the immigration, even though he had the green card. He was a permanent resident. So things were strange in my household, but I didn't know any better as a new immigrant. Not until I went to Goshen College did I realize, man, maybe my family is a little off. Why is my dad not burning out, right? Then I went to seminary, and when I was in seminary, I learned about how to not burn out, how to have a balance. You didn't know many ministers work 60 to 70 hours a week, right? Doing visitation, all kinds of stuff. So the seminary was good at letting me know, do things for self-care so you don't burn out. So I thought, okay, I'm gonna do that. But my dad, again, was not burning out. Later in life, my dad was ready to retire. My mom had passed away long time ago. I knew that he was going to be by himself. And I also learned that many people from his generation would suffer from depression after retirement. Many people from his generation, and I don't know if you can relate to this, they identify themselves or they develop an identity based on their work, right? Of what the things they did. And knowing that my dad was a workaholic and he enjoyed his work, I was concerned that he was going to enter into depression. So my then wife and I decided to invite him to join us. And sure enough, after retirement, within months, he was depressed. At that time, we were living in Houston, Texas. And so it was actually great to see him going to clinicians and for the clinicians to talk to him in his own language. It was great to see clinicians understand the immigrant experience. It was great to see clinicians develop a relationship with him prior to prescribing medication. And eventually, they diagnosed him with anxiety. And it to me, it was a big revelation. Yeah, he suffered from anxiety. That explained a lot in our household and how things were happening and how it grew up. Interesting enough, the clinicians were also Hispanic or Latino and spoke in his own language and developed a relationship. Now, fast forward years later, we learned that anxiety can run in the family. So my sister suffers from anxiety, her daughter, my niece, suffers from anxiety, and one of my children suffers from anxiety. So eventually we moved back to Goshen 18 years ago, and it's so interesting because Goshen in 1990 looked very different from what Goshen is today. The Latino Hispanic community has grown tremendously. And so knowing this fact, I started getting involved with the Latino community. Then when it was time for us to enter, well, to take our child for help for her anxiety, it was a very different experience. Both my sister and I struggled not only to find a clinician that understood our culture, but it also involved us in their care. We were, for better or for worse, this is my experience, we were pushed back as parents. And there was a shock to our system. There was a shock because we realized that perhaps the clinician did not understand cultural aspects. Like family is important, the community is important, that to understand and to better to help our family, to help our children, we needed to be involved. To me, skip a little bit. To me, trauma-informed care means understanding the immigrant experience. Looking back at my dad, he had many ACEs. We talked about the adverse childhood experiences. I'm sorry. He had many, and then coming over to the United States, not knowing the language, not knowing the culture, was also a shock. It was more than just cultural shock, right? For an adult to have to depend on somebody else for almost anything, for translation, from paperwork, just learning the system, be dependent on somebody else as an adult, especially an adult Hispanic male, that was shocking for him. And so to me, trauma-informed care is also going back to understanding that, you know, a lot of immigrants do come with traumatized experiences. Not all of them, depends on where they come from. But just the fact that they have to deal with new systems, new language, new culture, that alone can be difficult to take. And I know things are changing. Trauma-informed care, I think, has opened the doors to perhaps before you do service with a client, to ask questions, not to assume, right? To not re-traumatize, right? To allow families and the patients to let you know what is it that they are really needing and understanding. My child is doing well. She is thriving in college, but we had to get involved, make changes, ask for different providers. And some of the immigrants don't do that, right? They don't know they could ask for a second opinion. They don't know they can find somebody else. They don't know they could talk to a supervisor and demand changes. And again, that has seems like they have everything. So thank you very much.
Thank you so much, Jose. And next we have La Sierra Sharks. She is a certified support specialist at Mental Health Awareness of Michiana. La Sierra became a peer support specialist because she saw firsthand what it's like to suffer from a mental health illness. She believes that everyone deserves access to quality care. La Sierra wants to be able to build strong relationships with her peers in hopes of helping them feel supported. Thank you, La Sierra. A little nervous, guys.
You got this.
Okay, so I would like to just start by giving a little bit of background on myself. I've always suffered from anxiety. I never knew what it. Thank you. I never really knew what it was because it really wasn't talked about. So after having my son, after graduating high school, I suffered from postpartum depression. The experience hit me really hard. I really didn't know the language. I didn't know how to ask for help. I didn't really know how to find the support in my area or find support for me. And it wasn't that I didn't have it at home, it was just something that wasn't really talked about. No one asked me the right questions either. It was more so just, are you okay? What happened to you? And I didn't feel like those were the right questions, so I kind of just pushed through it as if it was normal. I felt like I should be happy because I just had this beautiful baby, right? But inside I feel like I was struggling in my silence. I did talk to my OB. I feel like she was talking more at me and not with me or to me. Honestly, it shut me down because I didn't feel safe in that space. I found a local postpartum support group for moms, and I went every day, well, every week, it was once a week. And I would just go just to get through my day, just to have someone else, around me that I could talk to. I met someone there and we shared our experiences, and her experience kind of just hit me and touched me. It was a no judgment zone with no pressure, and it was just pure honesty. And I feel like I needed that. That's when I realized how powerful it was someone saying, I've been through this as well and you're not alone. That moment kind of created a connection for me. It started my healing process, which is kind of what got me into wanting to be a peer support specialist. In my role, I work on a day-to-day with my peers, and I've just kind of noticed some things that I feel work for trauma-informed care and some things that don't. So I kind of just wanted to share those things that I've seen every day. So a few things that I've seen that has been working is giving my peers choices. Trauma-informed care works when people are given choices about their treatments, their providers, and their goals. Trauma often involves a loss of control, so when my peers feel they can make decisions about their own care, it helps them regain a sense of power. I recently worked with someone who previously struggled with going to traditional therapy, so peer support was suggested for him, and after working with him for peer support, he decided that he was ready to go back to therapy. We still work together in the peer support role as well. I've noticed that slowing down and building real relationships with my peers help providers slow down, and instead of rushing and going through checklists, the trauma-informed care works when there's time to build trust and not just treat the symptoms that they come in with. I often attend appointments with my peers and have seen providers who spend the first few minutes of every session just having to check in, how are you feeling today, anything that I need to know, rather than just going and completing the assessment for like my perinatal clients. Some things that I've noticed that hasn't been working, the lack of follow through after seeking support and referrals, which is really big. One of the biggest things that I've seen. When someone seeks help or has referrals made for them, there's often little to no follow-up after. I've had peers tell me they've reached out to local organizations for services, but received little or no follow-up. I said, I feel like that leaves people feeling unsupported and abandoned. A few of my clients have a very hard time navigating accommodations, and that can be a struggle for them. I've had a peer come to me and said, I have this disability, and I went to apply for a service. And when I got there, when it wasn't welcoming and there was nothing to show what type of accommodations there were for me. He was nervous, he didn't know who to ask, so the first person is me. So when we go in, then I'm looking for what kind of accommodations these local organizations would provide support for someone with a disability. Trauma-informed care for me, I feel like only works when it's consistent, genuine, and rooted in how we treat people, not just in what we say to people. And it starts by listening, valuing the lived experience, and making sure that care is both compassionate and accountable, which is why I decided to do this. Thank you.
Thank you so much, La Sierra. I love you. Now we'll open it up for questions. I would like to ask, Jose, you were talking about how when you were seeking care for your daughter, you ran into this issue of the organizations not being able to, or not having the habit of including the family in that. And you, as a trained professional, were probably able to push back on that. But a lot of organizations are structurally not set up to accommodate things like that. And I'm curious, similarly, La Sierra, when you were dealing with anxiety and no one was asking you the right questions, the organizations probably just weren't set up to know that they were asking the wrong questions. And now, like when you're going to organizations with your peers and finding that they're not accessible, they don't have accommodations, what have you done and what have you experienced that when trauma-informed care is butting up against structural issues, how do you address that, or what can be done?
That's a good question. To me, it has to, when you talk about agencies, clinics, I know that decisions are made for all kinds of reasons. Sometimes it's about budget, and sometimes it's about the board. I have the benefit of being a Goshen Community School board member, and I know that we have the power to hire and fire the superintendent. And so to me, finding and putting the right people in the right places where they can make decisions that affects the agency and practices and policies. That's when I think you see real change. Agencies, clinics, everyone makes decisions about budgets and money. Whether we like it or not, our system is set up to either make money, lose money, break even. Everybody worries about our system. I know it's a long answer, but the more the board, the more the president, the more the administrators, the vice presidents know about trauma-informed care, the more they understand culture and those differences, the better they're going to make decisions. Decisions are made one way or another, right? But the more they're empowered, the more knowledge they have, the better the hope is that they will make the right decisions. The hire the right people, the right HR person, the right clinicians, seek diversity in clinicians. I know it seems sometimes diversity is a bad word nowadays, but it benefits the whole. It benefits the agency, it benefits the community. The more diverse staff we have, my sister and I, she's another professional that also lives in the state of Indiana. We know what doors to knock, right? We know that the chain of command, what the chain of command is, and we don't get the right answer from this person. We jump to the other person. We jump to the other person, and we know how to get support from the community. The Latino community in Elko County is growing, and it's going to continue to grow. And the more this community becomes engaged, the more it becomes part of our fabric, our society, the better we all gonna be. So those are the working for the source. I could be working in different places, but I chose to work there because I know that I could make a difference. Never mind the salaries, right? I wanna be able to put my brain on stand in the system. Sorry to turn on.
Okay, so I'll keep it very short and simple. I really just feel like it starts with the training.
Yeah.
Yes. I feel like it starts with the training. For me, it was the questions that weren't asked properly. I feel like that was a lot of the providers, because I see most of the people then. Now I feel like the training that the organizations get are very helpful, or has been very helpful for my peers, and they are asking the right questions. I don't feel like I've been to appointments with my peers, and I don't feel like they were being re-traumatized, just because I feel like they've had the proper training.
Thank you. Any questions?
Before I ask my question, part of it is that you're with them, and that also adds to the person asking different questions, being a protective factor. So hoo-hoo to you. So my question is to you, you talked about the lack of follow through when you do a referral. Have you had an opportunity to talk to any of the agencies or organizations about that, and how some of the things that people could work on, or the things that have gone well when you've reached out?
So to answer your first question, no, I have not reached out to any organizations. Honestly, I'm really not sure how to go about that. That's probably the least question. But for me, so for instance, we have something called, we attend the pop-up pregnancy village, and we make referrals, most organizations make referrals there. We do that on a Saturday. On Monday, I reach out. And I just follow up on how the visit was with us. Most of the time I'm doing the screening, so just checking on them if there's anything that we didn't talk about in that setting. Is there anything they want to talk about? First, want to follow up with them. If it's another organization that they're struggling with, I try to sit down with them and help them reach out to that organization. Of course, I don't down talk the organization or anything like that. It's more so just what can I do or help you in that setting to try to reach out again. I really think there should be like a follow-up procedure. So when you're making referrals, I feel like it should be anywhere between 24 and 48 hours, because then they don't feel forgotten. Weekends, there's a little business days, but come that Monday, I'm reaching out because I want them to know, like, hey, she's the first thing or he's the first thing on my mind that Monday.
What are some things we could keep in mind as providers with the recent traumas that the government might be imposing on Hispanic Americans or Hispanic individuals?
That's a very good question. The Latino community in Elkhart County is diverse, and families, whether they're U.S. citizens or not, they know a family member who is undocumented. I think one of the things that we have to remind ourselves is that if you're a Latino, whether you're a U.S. citizen or not, because you're connected to your Latino community, Hispanic community, and because your dad, your uncle, your friend might be undocumented, that's a very stressful time for you. And we are a community that is very close to one another. So just for example, even though I'm a US citizen, I feel like I'm not even safe if the police stops me. If I get arrested, they're gonna assume I'm undocumented. They're gonna send my information to ICE just so that I can confirm that I'm a US citizen. Why do I, a US citizen, have to be assumed undocumented and go through the whole process? And so those are the things that we as a community are going through, whether, and so the whole concept, we're going just for the undocumented, and the rhetoric that politicians are using, it affects all of us. And it's a good reminder that we are all affected.
I'm back here. So, sorry, I'm not trying to be loud or that. So I am a skills coach for Josiah Whites. And a lot of times I was hearing you talk about when you were growing up, a lot of people didn't ask the right questions. What are those right questions specifically? Because sometimes in my field, I'm only teaching skills, but a lot of the times, the families I work with are in like poverty situations and hard situations. And I've only been in the field for a year, and sometimes I'm like, okay, like what's going on? Are you okay? But to you, that's not the right question. So what would be those specific right questions we could ask to maybe build a better relationship with the family and also show them that we care and support them?
I won't necessarily say that "Are you okay?" is that would bug me. I think it's more so of the what happened to you, because then they have to live that and feel, they're open enough to share that. Most times they're not. So are you okay? I won't say that is the worst thing, because most of the time it's a yes or a no, and then that could lead to a honest conversation. Hey, sorry. I just don't want to re-traumatize them. So depending on how open, so of course building a relationship with them first, right? Just seeing like how open they are with me. I kind of go from there. I don't ask a lot of questions as a peer support. In my training, we were taught, don't ask so many questions, let them be open to you. And when they start opening up, you kind of just open there. So it kind of, for me, it's like I kind of just feel in that moment, what type of questions I should be asking them. Again, I just don't want to re-traumatize, so I don't ask questions if I feel like they're not comfortable to answer those questions for me. So it's really a learning setting, and I really feel like it depends on each one of my peers. Each one of my peers is different. Some disclose everything, and some disclose nothing. But again, that comes from just building that rapport with them and just kind of seeing how open they are with you.
Great, thank you so much, Jose and La Sierra. 10-minute break now, and then we'll return and have Velshonna Luckey talking to us about self-care. Okay, we're ready to get started with our final speaker, and magically Jamie from the Aquatic Center figured out how to get things going again, so thank you, Jamie. Okay, so Velshonna Luckey is a native of Detroit, Michigan, and she is the executive director for Self-Healing Communities Collective, also known as Self-Healing Communities of Michiana. She's a columnist for South Bend Tribune, where she shares how readers can better care for themselves and their loved ones with the support of neuroscience. Velshonna is the founder of Pendulum Consulting, which focuses on executive coaching of underrepresented professionals. She also has a retreat business called Living in the Rest. In the spring of 2023, Velshonna joined the University of Notre Dame's College of Science, Neuroscience, and Behavior major as an adjunct professor. So we welcome you, Velshonna.
All right, so happy to be here with you today. I'm extra excited because I get to do a presentation with you all that's a little newer that I haven't done in this region. I've done on Zoom with people across the state and then with an organization in California. So I'm super excited about that. So you didn't know it, but you came for a self-care workshop. And I'd like to say that I've been teaching, doing retreats around self-care before it was a hashtag. But you all are gonna get a bonus in the sense that I get to share with you all the neurobiology of self-care. And what I'm gonna ask you to do is be uber, who knows what the word uber means? Uber intentional, like over the top intentional, to think about yourself. It's almost like a bad word for all of us helper folks. For many years, I did a lot of work. I was a youth worker for over 25 years. And I was one of those people, whenever I needed to do something good for myself, I had to like create a program or a retreat or something for everybody else. And so it's taken a long time and really good therapy for me to be able to fall in love with how to care for myself, honor it. And so I'm gonna give just a little bit more about myself, and then you all are gonna dive into activity. So this QR code, by the way, goes to our website. There's lots of free resources there. Please use it, download it. That is the intention. Our logo is not an organization. It is actually to identify a movement. So if you all have seen the safe station signs around the state, when you see the safe station sign, it means something, right? It means that lots of things, children can go there who are runaways, who be harmed. They know that there's somebody there that they can be safe. When you see this logo, you have to think movement. That means that if it's on a flyer, if it's in a presentation, that you know that the people who are doing this are participating in this movement care about ACEs, or adverse childhood experiences. They also are aware of the power of protective factors or the positive childhood experiences research, and they actually care about humans. Oftentimes you can know all those things, and we just heard about trauma-informed care. For many years, people would go to the workshops, they'll get a certification, and then they're trauma-informed, or their organization is trauma-informed. But you cannot mandate trauma-informed care. There's a whole journey to trauma-informed, which is trauma-aware, trauma-sensitive, trauma-responsive, then trauma-informed. Trauma-aware and trauma-sensitive, guess who that actually talks to? Everybody repeat after me. Me. And we skip over that. We skip over it. We don't know about self-care. We don't know about our own journeys. So we're gonna have some fun around that today. I fell in love with neuroscience. I am not a neuroscientist. And anybody who ever grew up hood, poor, all the things, listen, I am a testimony of just keep going, because life will bring you some beautiful surprises. Y'all, if my mama and daddy were here today, they would be amazed of all of the goodness I get to do. And I was invited to be even now when students say it, they laugh at me because I'm like, wait, who you talking to? Professor Luckey. What's going on? It's like a shock in my system. And so I fell in love with the brain. All of my degrees are in business. I fell in love with the brain because of trauma. My mother, we don't talk enough about chronic illness. Watching your parents have chronic illness, what that does to a kiddo. And so we now know that what my mom had is called spinal cerebellum ataxia, which is a neurodegenerative disease. On the brown card, if you turn it around, you'll see that there is a brain on the front. So that little bottom part that looks like a little raisin and that spine part coming out, that is the section where it shrinks. So spinal cerebellum ataxia is a rare neurodegenerative disease, and then we have a rarer strand in that it is late onset and it is hereditary. So unfortunately, 2 of my siblings are now navigating it, and every one of their children have 50% chance of developing it. So the beauty of neuroscience is that it is a newer science that is coming into the hands of everybody. And sometimes it's with TikTok. And sometimes it ain't right. And so when I get a chance to talk to college students and tell them, okay, look, I'm glad you're excited about neuroscience, but I just want you to know, when you see this logo, first of all, it's typically interns who are studying it for about a year and a half before we release it. And we're talking about not even releasing it to the public, we're releasing it to Dr. Nancy Michael, who gets to approve it. She's the director of the neuroscience major at the University of Notre Dame. And then it has to get by me, the non-neuroscientist, and I get to say, ain't nobody gonna understand that. So I'm super excited. You have some of those resources in your hand. Jan was on our team for many years. She helped us get to where we are today. And I'm so grateful that we were able to give her so much wonderful training that Lisa got to inherit her. And so I love when I get to be in this space. So I want to make sure that you have 3 sets of material in your hand. So you should have a blue card, a brown card with that brain on the front of it, and then a sheet that says Tiny Survival Guide. All right? So the first thing, this is our mission, the main thing that I love to talk about, okay, yeah, we got a lot of cool stuff. Anybody wrote a mission statement, you know that every word is fussed over, right? So lots of fun stuff, but this is my funnest part at the bottom. Celebration of our collective strength. So the researchers Self-Healing Communities model is a 20-year model out of Washington State. It is evidence-based. And guess what, y'all? They prove that taking time to celebrate has some neurobiological benefits. If you think about what happens, and even my introverts, there are some unique ways that we have to be creative about celebrating you. But when we can figure it out and you can design it for yourself, it is helping to heal your nervous system. Okay? And some of the sneak I got in today has to do with the nervous system. So the goal of the Self-Healing Communities Collective, so those who've been around for a little while, you know that's a new name. We do not have our own 501c3 intentionally right now because as a movement, we want the flexibility to kind of do some really unique things. We do have a fiscal sponsor, so we get to act as legally as a 501c3. So we just had our latest name change that the board changed it to. It was Self-Healing Communities of Greater Michiana because we were just in northern Indiana into Michigan. Then we got people interested across the state of Indiana, so we dropped Greater and left it Michiana. Now we got folks who are like, we need these resources. All these things in your hand that are created by us are called near-P resources. Neuroscience, epigenetics, A stands for ACEs, Adverse Childhood Experiences. R, the science of resilience. Don't worry about it, you'll get it later. P has a double hit of the research of positive childhood experiences and protective factors, okay? There's another workshop we could do about all that stuff. But for now, just want you to know, you have a boatload of neuroscience in your hand. And living the things that we're gonna talk about, you will see the benefits on your entire system, okay? So, we now are called the collective because we have people from across the nation. I keep talking about, you know, all of us got the same nervous system. We got a brain and we got all types of goodness running through us. And when we say we want to help people to prioritize the nervous system, I always say, but what is a nervous system? Show me some pictures. Tell me what you're talking about. Right? When you see another human, do you think of this? When you think of yourself, caring for yourself, do you think of this? I say oftentimes, we just drag our bodies through life. But we got all this. Self-care is all about stress, my friends. Okay? We have one stress system, two stress responses. You got the hormone response on the endocrine side, and then you got that electrical stuff over there. Think matrix. Okay, no, that ain't real funny, but I'm just saying, it just makes it come to mind. Okay, and then, do you think about this? All these organs on all the time, even when you're sleeping, all the time. It's always, our brain is always like, are we safe? Are we good? Are we comfortable enough? What's happening? What are we doing? How's my organs supposed? Do I need to run? Should the heart rate be going? And let me tell you, the amazing design of our bodies is that in a breath, some people on TikTok, they'll talk about like the parasympathetic state. And it can make you confused, like you're supposed to figure out how to live in a parasympathetic state. No, my friends. Do you know in a breath, we tap into the sympathetic and the parasympathetic with each breath? I'm sorry, Lisa, I just run all over the place. Okay? So, here's the thing, that breath in, your organs are like, whoo, we alive. What are we about to do? And that slow breath out says, oh, we're safe. We're okay. We can do this. So we're gonna do a breath exercise in a little bit. But I wanna give the foundation. Why should you care? I have until 12 o'clock. Okay, great. Why should you care about self-care? There are 3 stressors. So this came from the Harvard Center for Developing Child. At the top, when you look it up, it will say positive. From a neuroscience perspective, there is no positive stress. The body doesn't know the difference. That was one of the biggest messages that Dr. Michael had to teach me. The body doesn't know the difference, okay? So there's acute stress, that little bit, you plan a game, you're getting ready for a presentation, and you're like, ooh, a lot going on, you know? You can feel nervous, but nervous and excitement feels the same in the body, right? So that's the acute. Then you have the tolerable stress. The example that they give is divorce. Listen, divorce has a heavy stress load on everyone involved, especially the children, okay? But everyone involved, even some of your friends that have to navigate you having a divorce. Hopefully, ain't too many of us having to go through that, but I did, and I worked really hard to create I call it a self-healing communities divorce. If you see me and my ex today, you'd be like, wait, y'all ain't together now? Not in that way, we friends, right? So that's tolerable. And the reason why is because I had a strong support system. Children who have a strong support system. Most of all, people who will actually honor that divorce is hard. So that's the example that they gave, okay? And then you have toxic stress. So when I talk about trauma, or when you hear the word trauma-informed care, think toxic stress. They're interchangeable because we're talking about the stress dose on the system, all right? So when we're talking about learning about how to do breath, it is about being able to help the body heal. Have you ever gone through something and you're like, why am I acting like this? Why am I feeling like this? I remember one of the first doctors many years ago, and my body was tripping out. Nobody was talking about this. And he, in particular said, you know, what's been happening in your life and da-da-da-da. And I was like, well, I've been fine, but a couple of weeks ago, da-da-da. And he was like, you know, with women in particular, sometimes there can be a delayed reaction because you're just focused on the task at hand, right? Now I know that happens with a lot of people. So I'm gonna ask my dear friend Leah if she can read for us. So if you can turn over the blue card on the front side, and she's gonna read, yes, thank you.
The goal of the Self-Healing Communities movement is to teach everyone to care for themselves and each other in ways that prioritize the nervous system. Taking a deep breath not only maintains health, it promotes healing from the negative impact of stress and adversity. A deep breath is the easiest way to practice your resilience, and it is completely free. You are invited to practice the exercise on the back side and share the science with your friends and family.
Thank you so much. So if you flip the card over, and I love, Dr. Michael always talks about the things that can help with healing, everything, a lot of the things with building a self-healing community is free. Some of us old, I'm in my 50s, and I would say to all my friends who are 50 and older, do you remember a time that you could see a person in a distance and you'll be giving them eye contact, ready to wave? It happened, it was just natural. Now, we work really hard to divert our eyes. Do you know that is a harm? And you'll hear a little bit about why. Because I'll give you an early hit. We are hardwired for connection. As a species, we are hardwired. So when we see another human, if we know how to be safe or we grew up in that era of that, our body is, like you see the little wonderful dolls who like, oh, Billy coming. We have a little bit of that response in our nervous system, not here, in here. So when we talk about this stuff, a lot of it is free. And taking the time to do a breath. We won't do the exercise right now, but I'm asking you to take out time to practice the breath. And the biggest thing, there's lots of breath, box breath, all those different things. The biggest thing, I used to say, I'm getting back to saying it because now I'm practicing for 10K. Y'all, I think I'm so cool. I got a different body than what you see right now in my head. I used to say, I love martial arts. And I would say, I'm really a ninja in the inside. Right? So there's lots of different breaths. And if you know anything about martial arts, there are certain types of breath that help you protect your area here, how to hit. These breaths, from a self-care perspective, you want the exhale to be longer than the inhale. And you want it to be like you're blowing on a tea, not a candle, because the blowing out a candle is hard, okay? So it's that long breath out. So keep that in mind. Sometimes when you drive and when you walk in, you're like, I can't even remember what that card is saying, but she said, okay, breath in, breath out needs to be longer. So you could practice it all throughout our time together. But I want you to look at that right-hand side of the card and see, this is just some of the neurobiological benefits of a breath. When they told me this, I was like, why we ain't telling more people this? Why we just not learning this stuff? So much benefit. One of the young ladies that we did this with the other day, she was like, cleans out toxins? You mean every time I take a breath? She said, I feel thinner already. Just every time, right? Okay. So what you have in your hand now is this thing called the Tiny Survival Guide. This is actually not a Self-Healing Communities sheet. It is from the author of Trauma Stewardship. The reason why I love this card is because it's the first, this page is the first time that I learned that we have to metabolize stress. That there is a stress cycle that most of us don't get to go through because we got one stressor after another stressor, and then we go into another stressor. So we have to gift ourselves the ability to metabolize stress. I said metabolize, I only know about that with food. So you understand the process that you have to digest your food. You have to help your body with stress. So I'm gonna tell you my favorite that isn't on the sheet, and then you're gonna do an exercise, okay? Later on, I'm gonna show you a little bit of science around the power of touch, presence, support, and what it does to our nervous system. Baths, water does that to me. So going to a beach and submerging myself in water, or sitting in a bath and having that water cover me. Now I know the science of why that oftentimes is a safe place for me to cry. It's like, whoa. And I think it's a gift for all of the introverts in the room who may not like to be touched. Now there are some introverts, don't let me get it wrong, who love touch. Okay, but you need to be asking some questions, right? But you have to find ways that you can feel like nestled into safety. For some people, it's sitting in a lazy boy with their crochet, right? But that safety, what it does to allow yourself to be able to have the freedom to be like, ooh, we done been through some stuff. So as you're looking at this, I want you to take a couple of minutes to look, what makes sense to you? This is not about neuroscience. This is about preference, okay? Like on there's one that talks about spend time with your fur babies. That's not me. I love watching other people who like to be with their fur babies. But that's not gonna be a preference for me. So what you have to do with self-care is get to know yourself. Years ago, when self-care first started, you had to be wealthy to dive into self-care. You need to go to the spa, get your nails done, hair, travel. Y'all, that ain't really self-care. It's called the ability to capitalize on all the goodness in the United States or around the world. How can we make $1? But today is about, wait a minute. Part of the first self-care is learning to breathe, to care enough for yourself. I talk about as I got older and your belly started growing, you learn how to breathe without nothing moving. But that's not a good breath. Your whole, like with a baby, your whole body is supposed to move when you do that deep belly breath. Your whole body. So when you're doing the breath exercises, you have to also say, how do I get in touch with me? And sometimes that first question can lead to some tears because you're like, man, I ain't known me since I was in junior high. Elementary. I used to like doing. So that's what this right now I'm asking you to do. Take a full minute and a half, okay, a minute, and just put a little check mark next to something you know you enjoy or that you're curious about trying, okay? One full minute and be taking those beautiful breaths while you're doing it. Thirty more seconds. $15 seconds. All right, now pick a partner and share at least one of the ones that you selected. You got 2 minutes. Okay, so let's hear from a couple of you. What was that like for you to share, to identify and then to share? Let me hear just from 3 people. What was it like for you? Yes.
First of all, I think they should add bed rotting to this. Being in your bedroom, you guys haven't heard of bed rotting, where you just love to be in your room on the bed. Like it's safe and.
Yes, I call that vegging out. Yes. Yes. I write at the top of mine whenever I tell people put it up in their room so you can see it. So yes, she added one, bed ride. All right, anyone else? Right here.
So I identified that protecting my mornings would be one that well, but no. Protecting my mornings would be something that actually I'm interested in, because part of me's like, I'm a mom of 4, everybody gotta get to work, we gotta get people to school, like, how on earth does anybody protect their mornings? We got false, not false, but like artificial alarms and artificial lights to get moving in the morning, and like, but definitely run my morning on cortisol, so it would be interesting to like figure out how I could protect my mornings with all that going on.
Start with 5 minutes. I mean, literally, if you can find 5 minutes in the day, in the morning, that before anybody else, even if it's just a 5 minute that you wake up early and then go back until the next alarm comes on, over time, you'll see the journey. It literally, neuroscience is about integration. And you integrate over time. From a spiritual perspective, it's called spiritual formation, which means we don't change overnight. Neurobiologically, we do not. Guess what? We start off as this thing that can do nothing on our own. Then we become these grown-ups and we think we can do everything on our own. It takes time, including change. Change takes time. So what I'm introducing you today, these are fast hits, so that you can walk it out until the next time we're together, even if it's a year from now, right? Okay, one more.
Sorry, I wanted to comment. I have 4 little ones too, so I can relate. And one big thing for us is structuring, so kind of as much as we can. But laying things out the night before, having, like you said, that time to yourself earlier, so getting up earlier, that kind of thing. And my choice was simplifying, so learning to say yes to things and saying no to other things. If we don't do it, somebody else can get it done. We're not the only ones who can get it done.
Yeah, I remember a lady told me, thank you so much, thanks everybody. I remember a lady told me, you do know, I was a serious workaholic. If you die, they're gonna cry, they're gonna do a celebration, they're gonna be hurt for a while, then they're gonna post your position. So the reality that life actually keeps going, that sun is gonna come up, that moon gonna go down, no matter what. Oh wait, I gotta take care of myself. And I'm telling you, life is so much sweeter just with them. I started many years ago with 5 minutes. Literally set an alarm for 5 minutes, okay? So, gonna run real fast through this. This is imagine you as that baby. I don't know your stories. I don't know your journey. Based on statistics, there's somebody in the room who might have been truly neglected as an infant. I'm gonna talk about what humans need, and we always need it. We only talk about for the little of us, but it's for all of us throughout our lifetime. But as you see this connection, those arrows, right? I recently learned, look at me share some neuroscience I just learned, that the stress body that releases that stress response is very close to that same area that releases that oxytocin and all of the goodness. Because guess what? As an infant, when you are on high alert, you crying, the body is waiting for the response of comfort. And when that comfort shows up, the body is like, all right, we can keep going. Y'all, we can imagine that as an infant, but we don't think about that as us grown-ups in the room. Guess what? There's no point at any age that connection disappears. You're grown enough now, you don't need that no more. That is not how this human body works, okay? And so, sorry, right here it shows like heart rate, temperature, eye movement. And we're gonna skip this part because we're running out of time. But no matter what, that baby gets a response and all that brain function, all that hormone stuff gets to happen, right? And what it does is that alert system of stress, your organs are operating in a particular way, and then you get that response. As grown-ups, some of the response might come for ourselves, where we are saying, I got you. I remember my therapist had me do that, hug myself, and she's like, you take care of everybody. Stop for a minute. And when I was watching her, and we have a mirror neuron, and just her doing it kind of weirded me out. Watching her do it, and then she told me to do it, and then I felt how good. We shut off that stress response, and all of this goodness happened with the parasympathetic. Being able to heal ourselves. I also remember when she told me that, oh, wait a minute. I was telling her about some things that were happening, and she said, yeah, your body is starting to trust you. Well, first she said, starting to believe you and trust you again. My friend had me read part of a book called Wake Up Grateful, and there's a quote at the top of one of the pages, and it says, I told my body I wanted to be its friend. And it took a long, deep breath and said to me, I've been waiting for this my entire life. We're all waiting for us. And if you haven't experienced it with the community around you, you have to learn to practice it by these techniques. And it's gonna be a little harder. You're gonna need a little more support. But you have to go ahead and try to do it. So this is necessary. The connection is throughout our entire life. We think we go from dependency to what? Independent. But guess what? Interdependency. Our entire life. Our neurobiology. We have tried to convince ourselves that we could do it on our own. Pull yourself up by your own bootstraps. Ain't nobody ever did it by themselves. But we don't tell that story. Yeah. So this is a word I just learned too, biobehavioral synchrony. All of us, when we're in a room together like right now, y'all are my protective factor. And hopefully what I'm sharing is being a protective factor for you. And when we're in this together, you ever walk in a room and you not upset, but somebody else is, and all of a sudden you upset. Biobehavioral synchrony. And it's throughout our entire lifetime. We talked a little bit about when we are babies, but I love this picture because right now in our society, we even treat little kiddos like they grown. You should know how to do. No, I might have the words, but it ain't developed here. Younger nervous system need older nervous systems. So all y'all self-careness, guess what? Throughout your entire life, you're modeling this. And I wanted to show this, one, because of the exercise we just did on the big page, but also that brown card, the one with the brain on the front of it. The difference between the page we just went over and that card is that this is not preference. This is necessary for a healthy human, for a healthy nervous system. Now you have a negative bias, okay? And so you're gonna look at that card and you're gonna see all the things you're not doing well. It's just what happens. But I encourage you, you start with the one you are doing well. Then remember that celebration I talked about? Then it gives you the energy to go into the other things. So focus on celebrating the things you're doing well. And I put all these pictures up here thinking about metabolizing the stress. We gotta incorporate all these things, and it's put on the page that helps you realize that your body has chemical responses to you caring for yourself. This picture just shows that every time you do one of those things, there's a part of the brain that lights up. So remember I said this section here is the part that my family is impacted with spinal cerebellum ataxia. So you wanna know the first things I started talking to my sisters about and my nieces and nephews? We gotta work on this rest. Because look, got that rest. And here's the beautiful thing about a brain. It doesn't do it in isolation. It's constantly, just like our nervous system, it's constantly talking to one another. It's all working in concert together. We need each other. I'm gonna show you this image right here because as we as a community get better at self-care, we show up better for others. I just love this picture. We forget that the heart-brain has a connection, and now we know that there's a heart-brain-gut connection. And this is my last little thing. Every act of compassion, kindness, and grace extended to another person and or yourself can help heal and protect the brain. Every positive act creates a healthy and resilient nervous system. Positive interactions and experiences are required to form a flourishing brain. So thank you so much. If you have time, you can do the survey. Appreciate it. So sorry we didn't have time for questions.
Thank you so much, Velshonna, that was fantastic. Jan, actually, as Jan is walking up here, Jan is our education events coordinator, and I'd really like us to give Jan a hand because Jan.
Thank you, Lisa. We want to thank you all for attending our 2025 Spring Summit on advancing trauma-informed care, caring for our community, and we ended with you going home with caring for yourselves. You spent a lot of time caring for other people, and the committee wanted to make sure that we invested time in giving you some tips and some handouts on how you can care for yourself. So again, we want to give Velshonna Luckey another hand, something we committed. Our keynote speaker, who is no longer here, but she did a wonderful job sharing, Dr. Michelle Miller.
Playing cards, so you can just leave them on the table. We'll do it the next time they're off.
We want to make sure that you all, if you have not stopped at our vendor table, stop by and gather the resources that are available today. We're asking everyone as well to do our evaluation, which is the evaluation by 5 p.m. today, your name will be put into a drawing for a gift card. So I hope that's an incentive for you to take a few minutes and do our evaluation. If you didn't get a chance, we also invite you to stop at the table with one of our staff people and sign up for our newsletter. Our newsletter is sent out electronically and it allows you to know all of the events and classes that we offer. And the majority of the things, unless you're getting continuing education credit, majority of the things we offer are free. Also, we just have a few announcements. You can pick up flyers at the MHAM table. Somebody mentioned earlier about the pop-up pregnancy pop-up. The Pregnancy and Family Village pop-up will be May 3rd at the Charles Black Center. Invite you all to come and support that. We also are planning for our 5th annual Family Fun Fair at Howard Park. That'll be on May 30th, which is a Friday. We invite any organization in the room that would love to get a resource table. Last year, we had over 300 people attended. It's a fun event. If you don't want to have a resource table, you're welcome to bring your children. We have a lot of fun things from face painting, balloon twists. We have food trucks. We have all kind of arts and crafts. It is an exciting time. We had over 30 vendor tables last year. Just a fun event. This year we're gonna have some Zumba. That's it. This year we're gonna have Zumba and some cardio drumming, and so just a lot of fun things. It's we're promoting holistic family health, and so we want you to come out and support that. And please see me or email me if you're interested in having a vendor table. We want to invite all families to come. It's a fun event. I think that's it. We want to thank you.
There's one more. Sorry. So one other thing to be relevant for this group is that we're planning our June continuing education, and Crystal Whitlow will be teaching a class on evaluating and treating trauma. So I think given the context for today, if you join our newsletter, for sure, you'll see us advertising it. I will also try and send out an email once we have registration ready to this group. So, but she's a wonderful, wonderful teacher. So I encourage you to be that.
And lastly, the blue bags on your table are a gift from MHAM, a little self-care just for you. Thank you all for coming and enjoy the rest of your day.